hyphema, is that how you say it? Okay. Anytime you have a bleed into the eye, you want to know if that person is on an anticoagulant. Okay. So anticoagulants can go after two things. They can go after the platelets. So we have two ways to plug up a bleed. We can either go through the clotting cascade, through clotting factors made by the liver that circulate all the time, and we've got the platelet side. Okay? So platelets would be, the drugs that are going to affect platelets are going to be like your non-steroidal anti-inflammatory agents. So you can buy those over the counter. Ibuprofen, naproxen. They make the platelets less likely to stick together. Okay, so a platelet plug is one of the ways that we can stop a bleed. So if you use aspirin, ibuprofen, naproxen, Aleve, naproxen, those would be common names. So if you've got a person on those, especially if they're elderly, then you can, or they're taking large amounts, they can have abnormal bleeding because of that. So that would be one of the things you'd ask. On the flip side, if they are having pain and you've got bleeding present in the eye, you don't want to use those drugs for pain relief because they could make the situation worse. Okay? The other side would be the agents that then work on the clotting cascade. So the most common would be warfarin. So people who are going to be on drugs like warfarin or Pradaxa, Xarelto, those are the newer non-warfarin agents. So people have AFib, or they've got or they've got heart valves, or they've had a history of a clot in their legs or in their lungs. Those people are going to be on warfarin or an agent like that. Those are much more powerful. And if they're over-medicated and they're over-anticoagulated, then the time it takes for them to be able to stop a bleed is much prolonged. That's just what we do when we affect the clotting cascade. We just make it longer for them to be able to stop that bleeding. Okay? So that's the one thing you're going to want to ask when you've got a bleeding eye, especially in an older person. I would be asking them, are you on are you on something for your, they will often call them blood thinners, or an anticoagulant, warfarins. They'll know those if you use those. Are you on something for a clot? Are you on something for a heart arrhythmia? Okay, so with the subconjunctival hemorrhage, those are fairly minor. If you wanted to use an antibiotic because you were worried about preventing something or you had an abrasion that was going with it, then you would again be thinking staph and strep, and you would use something like erythromycin, bacitracin ointment. Now the traumatic hyphemas, then those, and so one of the things that you're going to check to see if they're on anticoagulant. Second is cycloplegia. I understand that's not something that you all are responsible for as well, correct? Did y'all even talk about it? Okay. Well, you can use these for two reasons. One is that you can, in order to be able to look at the eye and get it to be still, and for diagnosis purposes, you can paralyze. You can use a drug like that cyclopentolate, and it will fix the pupil. So it paralyzes the ciliary muscles, so they can't accommodate. But it's also a muscarinic blocker, so their pupils dilate. I put that in there just because we had talked about it in the autonomic nervous system, just to kind of bring it back and show you a real-life case of it. And it can also be for pain relief, so it kind of paralyzes the eye, and it can be used to help give them some comfort. Okay, so then nausea and vomiting. So because they bleed and we do not want to do more vomiting to worsen that eye problem, we certainly want to aggressively treat nausea and vomiting in these patients. So usually the go-to drug is going to be ondansetron as an antiemetic. Zofran, probably a lot of you have taken it. It's a very easy use drug to use. For most people, they have no problems with it. It's not as sedating as when we get into something like Phenergan or promethazine. The only thing you have to keep in mind is that it prolongs the QT interval. So if you have people who have a disease or on drugs that would also prolong that QT interval, that would be a direct contraindication. And you'll note in your handout there's a limit. There's a daily limit of 12 milligrams for how much you can give of the Zofran or the ondansetron. Okay, so we talked about a little bit about pain control. You could use topical anesthetics, so like lidocaine. What else did I give you? Proparacaine. See those canes at the end? Those are always anesthetics. Tetracaine. When the dentist gives you an injection, he's using one of those classes, or one of those drugs in that class. The other is that you could use all levels of pain control. Your acetaminophen would not be a drug that would cause trouble with the platelets or bleeding, so you could use it. You do have a limit on 1 gram, just because of liver toxicity with higher doses. We're not using non-steroidal anti-inflammatory, but you could also use narcotics. So the morphine, oxycodone, all of those would be good pain relievers. So from your standpoint, is your role in this usually a triage role? Is that how you all addressed it, or how Professor Fetters addressed it?
Sort of.
Some is triage, some is treatment.
Dependent on.
She said, yeah, there's some things that she said immediately just send to an ophthalmologist, and some
Okay.
things we can hear a lot.
Treat and get them started and then
But the
reevaluate.
bleeding eye depends if it's over the anterior chamber, then it needs to be immediately referred, right?
Yeah.
So if it's not as severe, then I think we can handle that.
Mm-hmm.
That
Okay.
comes to urgent care.
Yeah, I bet. Did you see a lot of eye trauma? Did you really?
Well, yeah, people who got metal and that sort of thing,
Wow.
but the severe stuff like herpes zoster, that sort of thing goes like the other way.
Absolutely. Okay. All right, corneal abrasions. So, and you can correct me if I'm wrong, so I assume this is a fluorescein dye that they've used to show the irregularity in the cornea, so you can see a mild abrasion there. So the big thing here is preventing a superinfection. So often these are not infected, but you want to prevent it becoming infected. So again, you're going to go with the similar organisms, the staph and the strep. Catch up with y'all. Oops. So adherence to therapy is going to be a big thing here in impressing on people to take it's always with antibiotics. People never want to take them for the length of time. But it's really important to talk to people about doing that and reinforcing that. So preserving vision, minimizing pain are our goals. Monitoring is going to be that, I was amazed when I read this, that these mild abrasions will heal overnight. How incredible is that? I had a new appreciation for the eye. So purulent discharge, so signs of infection, we'd be looking for a change in vision, decrease in vision, and ones that are not going to heal, and ones for children that they won't open the eyeball after 24 hours. So consistent with what you heard this morning. Okay, so here, let me go back. Let's look at your handout. I don't think I put the ones in for that weren't contact lens. So again, erythromycin or trimethoprim polymyxin is a really good broad spectrum antibiotic, 2 antibiotics in one. It's a drop, the other one's an ointment, so it gives you for people who did not want to use an ointment. And again, they can use anything for dry eyes as for comfort as well. Here we talked about, so here, because we're not dealing with a bleeding episode, we could use a non-steroidal. They're very effective in those kind of pain. And they're cheap, you buy them over the counter. Or you could use a non-steroidal anti-inflammatory ophthalmic. So both of those, ketorolac or diclofenac, could be used. But it's probably better just to go with a systemic. If the pain could not be controlled, you could certainly always go with an opioid. Avoid the topical anesthetics and never use the topical corticosteroids. Sometimes from what I've read, and you all correct me that have been in these situations, but that they will use that cyclopentolate like in kids. It will last about 48 hours, so they'll put a drop in before they send them home. It lasts 48 hours. By then they're usually healed, and it's a very good pain reliever, easy for the kids. So there might be a situation where it would be really good for the parents, good for the child, and they may use it one time. Okay. So here we're back to contact lens wearers again. So again, it's Pseudomonas and it's the fluoroquinolones. Ofloxacin, ciprofloxacin comes as a drop or an ointment, whichever way you want to go. Here you could use an aminoglycoside, so tobramycin, gentamicin would be two in this category. Also come in drops and ointments. And again, you're going to want to tell them to stay off those, wearing their contacts until they're fully healed. And again, for kids, if we can use an antibiotic ointment over drops, that would be preferred. Okay, any questions or things I left out? All right, so herpes simplex keratitis. So here our goal of therapy is stromal damage and scarring. And to try to get the most efficacy without toxicity, because these antivirals are not as easily tolerated as some of the other antibiotics. And then just the response to therapy is what we're going to be monitoring for. So here are the agents that are commonly used. There's the oral acyclovir, ganciclovir, trifluridine, and vidarabine. So from what I've read over the years, it looks like people have moved to using the systemic antivirals because they're just as effective and they're easier to use than having to worry about drops or ointments. The problem with acyclovir, it's kind of an odd one. It's like, take it 5 times a day. Well, how do you do that? I mean, that's kind of odd. Think about having to divide your day into 5s and take a drug. So that one's a little bit odd. The other is that the topical antivirals can cause a lot of toxicity to the cornea. So if we can avoid that with an oral, then that would be a good thing. So response should be within 2 to 5 days, complete resolution within 2 weeks. Usually what they will do is, with the topicals, is they will dose them for several days until a response occurs. Then they will back down the dose to decrease the risk of the toxicity.
But until then, it's 5 times a day?
Pardon?
But until it gets reduced, it's 5 times a day?
Right, it's 5 times a day. Now, I didn't see a reduction for the acyclovir, but I think I read where you could go down to 3 times a day. But you'll see, I can show you a better example in the ganciclovir and then the trifluridine, is that it's every 3 hours while awake, and then you can decrease it to 1 drop 3 times a day for 7 days. So that's quite a better for the patient. And notice that with the vidarabine, that it is often effective against strains that are resistant to the trifluridine or the acyclovir. Your immunocompromised patients, they recommend that they're admitted for IV administration. So I wanted to show you what these drugs do. So these antivirals what they look like the base pairs in DNA synthesis. So this one I think looks more like guanidine. So it gets into the cell modifies it by putting 3 phosphate groups on it from ATP, and converts it into a more of a nucleoside looking molecule that moves into that nuclear membrane. So it's going to move from the cytoplasm into the nucleus, and there it gets incorporated into the virus replicating itself. However, when it replicates, it fails to add on at the end this hydroxyl group. And because that hydroxyl group is not there, the next nucleoside can't be attached. So it stops chain replication. So that's how those drugs work. I always find it fascinating how drugs do what they do. But so that's its mechanism of action.
How effective do antivirals tend to be? Because I know I shadowed a bunch of PAs that would actually kind of tell patients not to get them, but they would say these might not be terribly effective.
For this,
Does it vary depending on the antiviral?
that I don't know. You mean for the indication for what you're treating?
Yes.
Well, I'll just say from what I've read. Now I don't have experience, clinical experience with this, but from everything I've read is that you put yourself at great risk if you do not treat this keratitis. That it can certainly evolve into a much greater, I don't know what infection it is, but it also can cause all those dendritic and changes to the stroma are what can occur, and then blindness can occur secondary to that. So from everything I read, these are very effective drugs. It's getting people to take them for the length of time that they need to take them. But I didn't see anything out there that said that it was optional. So,
Like this versus Tamiflu, there's a huge difference.
Yeah.
Like, not all, I don't think all antivirals are
okay,
great.
good point.
But this one, you need it.
This is curative, as far as I understand. This takes care of the infection. Tamiflu, the only thing you're doing Tamiflu is you are shortening the duration of the disease. That's it. So you're going to get somebody back to work 2 days faster. So sometimes you have to look at that amelioration of a disease versus a cure. Now those are different. Now that's true. That's very true. But you know, if you've had the flu and you've got children, or you've got no leave from work, then getting back 2 days faster would mean a lot, right? So I think, or getting a child back into school 2 days faster would mean a lot. So those are good points. But to your question, I don't know. From everything I read, you just don't mess around with either this one or the next one. Is that?
We've learned that today. I think it definitely, like, it's dendritic and causes damage to the muscles.
It might be something to ask Professor Fetter. She may see this a whole lot more than I do, and so she could address that.
I think my confusion was the Tamiflu. I think I was thinking of them as the same mechanism, and they're not.
Anything to add? Did you see these at all?
No, not usually.
So this is a nasty one. So herpes zoster ophthalmicus. So this is the same virus that caused, you all probably didn't have chicken pox. You probably. You did? Really? So when did the, okay, so my son's not, he was born in 93. I think he had the vaccine in 95. So you all must precede that, or else they just didn't give it to you. But I remember having to ask to get it. And I had a great pediatrician, but I don't know if they just weren't pushing it at that time. Okay, so you all had this, you're all susceptible to getting this. Okay.
I didn't know.
You never had it. Some of you
I
didn't
didn't
have
have
it.
it.
Did you have the vaccine? Okay, so
I'm younger.
so you're lucky. You're lucky. So those of you who had the disease, then this is one of the problems. So you know that the virus can live in the dendrites of nerve terminals for long periods of time, and then as the immune surveillance and ability to keep it at bay wane over with age, even though I have seen them in 14 and 15-year-olds, you can certainly get a secondary infection. So here, this is quite an impressive infection and can certainly rob their eyesight and leave them with a post-herpetic neuralgia that is just awful to control. So here it's treating it, preserving sight is what you want to do, and make them more comfortable. So the treatment's going to be local wound care, analgesics for pain control. You can certainly use the lubricating drops again to make the eye more comfortable and protect that cornea. So here it's antiviral therapy. Here it's important to get it started within 72 hours. And continuation is 7 to 10 days. Now here we're talking about oral antivirals. So acyclovir, famciclovir, valacyclovir. For those with serious disease, you can use IVs. Oral corticosteroids are often used because the inflammation is impressive, as you see in that last picture, but only in combination with the antivirals. Any of your parents had, I'm blanking on the name, what's the, shingles, thank you. Ever had shingles?
I had shingles a couple
You had
years ago.
shingles, so you were one of those young folks that got it. You want to
19.
tell us your experience with it?
Yeah, so I was actually impressed by how incredibly fast the doctor knew what it was. I caught it really, really fast. I had a couple of like blisters here on my back, and so I went in and I told him about it, and then I lifted the back of my shirt, and he saw it for like 3 seconds. He goes, "Oh, that's shingles," because it had the belt, although not much because I just caught it, because it only goes halfway, like you can see in that picture, and then it was starting to spread, but got some hydrocodone and some of, I think one of the clovirs, cyclovirs.
Okay.
We caught it really fast though.
So did you have pain that lasted beyond the treatment of the outbreak?
I think because I caught it before it was very painful. Like it was not bad because I got it so fast. And it went away pretty quickly. So, I mean, a little bit, but I don't know if it's because I'm much younger than most people who get it, but nothing that I remember being terrible.
Anybody's parents have it? Yes.
My mom, she was in severe pain.
Yeah. Did she have pain for an extended period of time after that? Okay. Anybody else? Yeah.
My mom had it and gave me chicken.
Really? Oh, wow. Wow. Okay. Something to keep in mind. My mother had shingles, and she had it in a very lower dermatome over her hips, and her pain lasted for 2 years. They had to treat her with lidocaine patches over there because it was so incredibly painful.
Was it like internal pain or like skin pain?
Oh, I never asked her. Probably more. I don't know.
They vaccinate for it now, don't they, shingles?
Do I?
They vaccinate for it, don't they?
Yes, so now you can get starting at age 50, you can get the herpes zoster injection. Yes. Good to remember to ask the patients. Okay, this next section, I gave you a whole lot more information than you need on the glaucoma. The reason why your faculty want you to have this is because of the side effects. That's what you'll deal with. So I understand you probably don't treat the glaucoma, but you will see it in many of your older patients, and its adherence is huge because it usually takes multiple drugs, and it's just the coordination of them. They're expensive. And you know, here's one thing to take away. Diseases that don't cause many symptoms, it's hard to get people to take drugs for them. So when you have somebody who has never had a heart attack but has high cholesterol, and you want them to take an expensive drug forever, most of them won't. I think that the average adherence with statins at the end of 1 year is 50%. So blood pressure doesn't make people feel bad, but you give them drugs that make them feel bad. Okay? Glaucoma, doesn't make them feel bad, and you're making them put eye drops in their eyes for the rest of their life, and expensive eye drops, on top of everything else they have to do. So this is one of the problems, adherence. So anytime you see a patient of yours that's got glaucoma, just always ask, how's it going? How do you manage? What do you do to remind yourself? I always ask them, how do you remember? Most patients will tell you a routine. That's usually good. I'm usually looking for, tell me what you do. I line up all my medicines, and I take them down one at a time in the morning, and I put them back one at a time. Something like that. Morning medicines usually aren't much of a problem. It's the rest of the day where people start to break down. Using a pill box is usually a good sign. So asking them how they do it would be great. Most of these drugs are given at night. So older people tend to fall asleep early, or they fall asleep while they're watching TV. And so when they get up, they may not want to take them. So just those kinds of knowing and watching, watch your parents, watch your grandparents. And that'll be great to help you start to ask patients about, how are you doing that? You take them at 10 o'clock, okay, well, what do you do if you go to sleep? What do you do if you fall asleep? Well, I still take them at night. Or how long does a bottle last you? That's always good, because they can't ever, it's like when I ask people, how much do you drink? I don't drink very much, relative term. I just drink a glass a night. Well, my glass is this, your glass is this, okay? But if I ask them, how do you buy it? They never fail to tell me. I buy a fifth. How long does a fifth last you? They can't calculate it out fast enough to tell you an answer that would be acceptable, that they think is acceptable to you. So sometimes those kinds of things help so you can start to get a feel for what they're doing. Not catching them, but so that you understand what they're doing. Okay, so with the drugs that we use for glaucoma, the goal is to lower intraocular pressure. Because if we don't, over time, that increase of inability to get rid of that fluid then starts to put pressure on the back of the eye, so you can get visual field loss, optic disc changes. So it's really important that they take their medicine. And I like this a lot, so you might look at it when you have a chance, because it shows you the flow of the fluid in the eyeball, and it shows you where each of these different drugs work. So they're either going to decrease the amount of fluid that is made, or they are going to open up and allow the fluid to move out better. I am not going to ask you that stuff, I just think it's cool. Okay, so we have, if you look on pages 18 and 19, let's see if it goes on, and 20, these are the categories. So there's the prostaglandins. I put the names down there just so that you would have some familiarity with them. I will not ask you them, but it'll start to give you at least a reference point. So the prostaglandins are one group, beta blockers another, very, very common. The alpha-2 adrenergic agonist. Then the carbonic anhydrase inhibitors, we've got some we can put in the eye or we can take orally. And then the cholinergic agonist, also a very common one, older drugs that have been around a long time. So let's look at their side effects, because that's what we're going to focus on. So the prostaglandins they are great drugs, and they are very effective at lowering intraocular pressure. And they're usually well tolerated, so they're usually first line, but they are expensive. So the cool thing that they do that even a drug company has has made some money off of is that hypertrichosis and hyperpigmentation around the lash. Look at that.
Nice.
Wouldn't you kill for? Latisse. Latisse is the name of the drug.
Everybody does it.
So, better living through drugs. So then there's iris pigmentation, so you can see pre-treatment and post-treatment. So just a deepening, usually it's the browns in the eyes. Usually blue eyes are not as affected as much, but if you've got rust color or brown in that eye, it will just become a deeper color. It doesn't change the iris, it's not harmful, it's just something people may notice over time. The other two things that are worrisome is a uveitis, or worsening herpetic keratitis can occur. Okay, beta blockers, these are the number one. This is the one you really ought to pay attention to because often people who are using beta blockers in their eyes are also taking a beta blocker, so you can get additive effects. So beta blockers are beta adrenergic blockers, so beta 1s, beta 2s, they're everywhere in the body, heart predominantly, also the lungs. So people who are on heart medicine, so it can greatly decrease their heart rate, and decrease blood pressure. It can decrease the contractility of the heart, so it can worsen heart failure. It can cause conduction defects that would lead to arrhythmias. In the lungs, our airways are surrounded by a layer of muscle. And those, if you block the beta effects, then those muscles tighten or contract and make the airway smaller, so making it harder to breathe. So they can worsen the effects in COPD, breathing, or asthma. It also can block the symptoms of hypoglycemia. You see, I put this in your handout. Remember that table I said keep a hold of because you may want to use it? I cut and pasted some of it back in so you can start to look at those receptors and you can start to predict things on your own. So this is one of the interesting things about the sympathetic nervous system is that, remember, you've got some that are cholinergic on those postganglions, and so sweating is actually sympathetic control, but it's a cholinergic postganglionic neuron. I'll never forget it because I have never had trouble in standing up in front of people. It's just, I was a teacher from early on, and so I got very used to standing in front of people, but for some reason, back when I was a resident, after I had done my doctoral work, I had to give a presentation to a group of people. I don't even remember who they were. I just remember what happened. Well, this was the time where everybody was using beta blockers for performance anxiety. I don't even know if they do it anymore, but it was a big thing back then. So somebody gave me 10 milligrams of propranolol and I took it. Well, I sweated, I drenched the inside lining of my jacket that I had on because I blocked everything else sympathetic but that, and the sweat just poured off. I never do it that I would notice otherwise, but that day it got me, so I've never forgotten that. So here's the problem with low blood sugar is that when your sugars get too low, the one way that your body can raise those sugars up is it releases a lot of norepinephrine. And that norepinephrine can act on the liver, and it can through a very quick release mechanism, allow the liver to release a lot of sugar in an effort to raise blood sugar. So when you release a lot of norepinephrine, what symptoms are you going to have? If I flooded you right now with norepinephrine, how would you feel? Shaky, your heart rate would go up, you might get tremulous. And the other thing you would do is your sweating would go up, so that kind of that sweaty, I'm going to faint feeling would come up as part of that. So the problem with beta blockers when you give them to a person with diabetes, and it's not an uncommon combination because we use beta blockers a lot for blood pressure and for post-MI, and that's very common in people with diabetes. You give that beta blocker, you mask all those adrenergic symptoms. So the first symptoms that people have when their sugars get too low are adrenergic. So you block all those except sweating. So that's one of the things we tell folks is that you'll have the sweating, but all these other things are going to be masked. So that's why it's up there and listed. Okay. So we want to be careful in people with heart disease, lung disease, diabetes. I didn't get a chance to look up the myasthenia gravis, why that is, but I included it because it seemed to be one of the major diseases that can be worsened. So your little red flag should go up. I got somebody who's on an oral beta blocker and they're on a eye drop with a beta blocker in it. So here technique is really important. So getting them to press that tear duct and letting that drug get absorbed goes a long way to preventing those side effects. The alpha-adrenergic agonist. So these are more moderate, these would probably be more second line, add on to the other agents. So their systemic effects are the dizziness, fatigue, sleepiness, dry mouth, and decreases in blood pressure and pulse. So remember this diagram that I gave you back when we talked about the autonomic nervous system. Tricyclic antidepressants and these alpha-adrenergic agonists are part of reuptake phenomenon. So what happens is that you block that ability to reuptake all the norepinephrine that you've released out into that synaptic cleft. So they get increased side effects from that. Using them with a monoamine oxidase inhibitor, what did it do? What did monoamine oxidase do? How did we get rid of norepinephrine in that synaptic cleft? Remember, there were 3 ways. You can take it back up,
Break it down.
you can diffuse out in what?
I said the net receptor, or the
Okay.
uptake.
Or we can enzymatically get rid of it. Okay, and so that MOAs, they get rid of it. So you block those, then you just got more norepinephrine. So you can worsen any of those symptoms. So again, heart disease is going to be big. So think of the heart whenever you're looking at somebody with glaucoma, because they're all usually going to be elderly, or older. So they may very well have underlying heart disease. The carbonic anhydrase inhibitors are really interesting. They're usually fairly well tolerated, but they can cause a systemic acidosis, which can make people feel awful. And so that malaise, fatigue, I don't want to eat, I've lost my appetite, my food doesn't taste right to me, all of those are common. So people who are at risk for an acidosis, like COPDers, usually have a respiratory acidosis. Those folks would have more trouble. Liver or kidney disease. So any of your big major organs, lungs, kidneys, liver. Addison's disease isn't going to be very common. But diuretics, in combination with those carbonic anhydrase inhibitors, can significantly cause hypokalemia, which can lead to arrhythmias. So we use those. These used to be very common in glaucoma. They're now more add-ons or third-line agents. But we can also use them, sorry, I put in the systemic. It's because I don't think the topical had as many. The topical, it was mostly local and adverse effects for them. So it's the systemic ones that are going to cause these trouble. The cholinergic agents, here, meiosis. So meiosis is which one? Pupils get big or pupils get small? Small, okay, so meiosis. So night vision, decrease in night vision for your elderly may be a problem. They get a headache or they get a brow ache. It's really unusual. So pay attention to those. Pain around the eyeballs. Systemic effects are nausea, vomiting, diarrhea. So they're really again, you're looking at cholinergic agonists, so that SLUD that I told you about, increased salivation, urination, defecation. You see some of those coming in there. Okay, any question about the glaucoma? So with these, we're only going to focus on the side effects. So the rest of the stuff, I just gave it to you for extra. When I do my handouts, I write them towards thinking about you next year. Not only here, but next. So hang on to these. They won't be your only, but when you go onto a rotation, highly advise you to read through those. Then whoever you're under is going to tell you, the type of text or where they like to get their information. But these will be good guides or just overviews for you that hopefully will kind of get your mindset back into the drugs and what you're going to be seeing there. Okay, orbital cellulitis. The one thing I remember this from my training is this is really bad and you need to look at it right away, is what I always remember about. Because I didn't spend as much time training with children. It seemed like this is where this came up a lot. So the big goal is they're getting rid of that infection, preserving their eyes. So also following infection parameters, so their temperature, symptom resolution. Again, we're going to use broad spectrum antibiotics, and we're going to use quite a few of them empirically, and then once we've got culture back and we know what we're dealing with, then we'll more tailor the antibiotics for those organisms. So staph again, strep, and your gram-negative bacilli. So you need very broad coverage for these. And we're going to be worried about methicillin-resistant staph. You will hear about that until your brains fall out, because it is such a difficult bug to treat. So the drug of choice is going to be vancomycin. That is our best drug against MRSA at this point. We give it IV, so you've got to be admitted. It also requires therapeutic monitoring, not only for the therapy-wise, but also to avoid toxicity. So whenever we're looking at IV antibiotics, we're always wanting to get the drug levels in the blood so much more, many times higher than what the minimal inhibitory concentration of that organism is going to be. So when we're going for very high peaks, we have to let that drug fall off over time, for 8, 12 hours, in order to avoid it becoming toxic again, or causing toxicity. So this drug is one of those that we'll talk about trough concentrations when we talk about antibiotics in more depth, but we're going to measure the level of that drug in the blood right before we give it again. That's what a trough means. So the peak, the highest level it produces in the blood, trough always comes right before you're going to give the next dose. So we're going to use the vancomycin, that's for the MRSA, and then we're going to use one of the others. So ceftriaxone, cefotaxime, the cephalosporins, or ampicillin, subactam, we're going after the gram-negatives there, piperacillin the same. And we should expect the person to respond within 24 to 48 hours, that they're getting better. So if they have a serious allergy to a penicillin or a cephalosporin, then they can be treated with a combination of vancomycin and a fluoroquinolone. So that would be Cipro or levofloxacin. So this is one of those things that you really need to commit to memory as an alternative, because these are life-visioning, threatening infection. Now, once in a day or two, when you get cultures back and you know what you're dealing with, if you are dealing with a methicillin susceptible strain, which is referred to as those MSSAs, then you want to switch them, because we want to preserve our ability to use vancomycin. So then we would switch them to something like oxacillin or nafcillin. See those cillins on the ends? Those are penicillin derivatives. And then we switch them from IV to oral in about 3 to 5 days, depending on how well they're improving, symptoms are resolving, they're looking better, not as toxic. Then oral therapy is going to be clindamycin or trimethoprim sulfamethoxazole, very broad coverage, very good coverage. And then in addition to one of the other agents that are down there. Again, for kids that have serious allergies to penicillin or cephalosporin, those drugs are very, they're like cousins. They look very much alike. Often people have allergies to penicillin, severe allergies to penicillin will also have allergies to cephalosporin. So there you would want to know kind of the nature of the reaction they had or the allergic reaction they had experienced. In total duration of treatment is 2 to 3 weeks. And then the preseptal cellulitis is, I think it's our last thing. So, monitoring parameters again. We want to make sure they're responding to therapy. Organism coverage, again, same kind of thing. Strep, the Catarrhalis, the Moraxella, and the staph, and then H. flu. Here the thing to remember would be is if they have not, if you've got a kid that's not been immunized against Haemophilus influenza, you would want to have an antibiotic on board to cover. So treat for 7 to 10 days. Monotherapy, so here's one where you can use an oral therapy, clindamycin, or a combination of, and these would be oral agents, so the trimsulfa plus one of the others, amoxicillin or amoxicillin clavulanic acid, depending probably on your sensitivity in your area, and then one of the third-generation cephalosporins. Okay. So take a look all over those. I will be back with you again on Friday. We'll look at just the nose, and on Monday we'll look at just the oropharynx. So keep in mind those objectives, because there's so much stuff you're going to have something that's going to sort it out. I am not going to ask you doses, because they're huge, and some of it you'll have to look up. I've asked on your boards if you need those, and the answer I'm hearing is not very often. So I'm going to try and find out which of those you do need to know doses.
I could be remembering this wrong because this was just earlier today, but I think that Professor Fetters was kind of specific about not giving antibiotics for preseptal cellulitis. What's your take on that?
I didn't see anything that said not to do that.
Isn't it if it hasn't spread within a certain amount? Is that? Am I totally wrong?
I thought, yeah, but I asked because she said just a warm compress. And I could be remembering that wrong, but I remember asking something about that.
And I would keep this as if antibiotics are warranted, here's what you do.
Okay.
So I don't know how you initially determine if a cellulitis is just due to inflammation or if it's due to an infection. Wouldn't be mine.
So as far as like the classes, like I was getting to know those, the individual drug names, we're responsible for bringing those to just the ones that you said, no, don't know.
So in the objectives, it's no first line and no second line, know what you do for an allergy. So go by the specific names.
Okay.
Because that's
Like
what,
the trade name or?
no, I've given you I've given you all generics. So let's just, to me, generics better, because you can't mess it up. Focus on those objectives. It would be good if you'd kind of give this an over, let me make one other,
Okay, guys.
Guys.
at least by Monday, look it over and go, oh my gosh, how in the world am I supposed to learn all this? Look at it through the objectives, then come back with questions. And then I can always talk to the faculty, because it is a lot of stuff. It is. A lot of it I've given you that I'm not going to test over, doesn't mean it isn't important, it's just that I think I have 10 questions on this, I can only do so much. Okay? All right, I will see you Friday at 3 for the note.